Hello, everyone, and welcome to the ROSA Worldwide Webinar Series. My name is Mike Reed. I'm the Chief Scientist at ROSA, and I'm the host for today's webinar. I'd like to remind everybody to check the website for upcoming webinars in our webinar series. They occur about once a month, usually on Wednesdays, with a break for the ACOP conference this year. If you would like to ask questions during today's presentation, there's a little button at the bottom of your screen labeled Q&A. You can enter your questions there, and the speaker will answer them at the end of the presentation. Our speaker today is Dr. Haoji Zhu. He is a professor in the Department of Clinical Pharmacy at the University of Michigan College of Pharmacy. He graduated with his PhD from China Pharmaceutical University and also has an MBA from Nanjing University. He completed his postdoctoral training at the Medical University of South Carolina. His research focuses on identifying genetic variants and environmental regulators that impact pharmacokinetics and pharmacodynamics using an integrated multi-omics approach and machine learning. Please welcome Dr. Zhu, and we're looking forward to today's presentation.
Hello, everyone. Welcome to the webinar. Yeah, thank you, Mike, for your kind introduction. So today, I will talk about the two recent projects in my lab. And the first project focuses on using machine learning to predict the trough concentrations of the immunosuppressive drug tacrolimus in kidney transplant recipients shortly after transplant. Let me click this. Okay, it works. Okay, the second project, which I will cover in the later half of the presentation, is to use a combined metabolomics and machine learning approach to predict graft rejection in kidney transplant recipient. So let's begin with the first study, predicting tacrolimus trough concentrations in kidney transplant recipients during early post-transplantation using machine learning. So for those who might not be familiar with immunosuppressive medications, tacrolimus is a cornerstone of immunosuppressive therapy after a kidney transplant to prevent the rejection of the transplanted kidney. However, managing tacrolimus pharmacotherapy is very challenging due to its large inter and intra-patient variability in PK and its very narrow therapeutic window. As you can see, there is a fine balance between over-immunosuppression and under-immunosuppression. So if the concentration of tacrolimus in the blood is too low, the patient is at high risk of both acute and chronic rejection, which can lead to the loss of the transplanted organ. On the other hand, if the concentration is too high, it can cause serious side effects, such as kidney damage, increased risk of infection, and some long-term problems like malignancy and diabetes. So both over and under exposure of tacrolimus are associated with adverse clinical outcomes. So we want to keep the drug level within the target range. In clinical practice, we regularly measure tacrolimus trough concentrations and adjust the tacrolimus dose based on these trough concentrations. However, it is not an easy task because of the large inter and intra-patient variability. In fact, only about 1/3 of patients can reach the target level at the time of discharge from the hospital after kidney transplant. So some patients can even take many weeks to reach the target level. So to address this challenge, we wanted to develop machine learning models to guide tacrolimus dosing to enable more patients to achieve the target level and reach the target level faster. So in this study, we used two data sets. Our primary data set is from the University of Michigan Transplant Center with 1,624 kidney transplant patients. 376 out of those patients had a genotype information. So as we know, genetic variants of some drug metabolizing enzymes, such as cyclone P450, 3A4, 3A5, and transporters like ABCB1 can affect the tacrolimus PK. So we can use this genetic information to predict tacrolimus trough concentration in this genotype subset. We also included an external validation data set from the MIMIC4 database with 164 kidney transplant patients to test how well our models perform on a different patient population. The MIMIC4 is a publicly available database generated from the electronic health records of the Beth Israel Deaconess Medical Center in Boston. So this table shows the demographics of our study subjects. You can see some significant differences in race, weight, daily dose, and trough concentrations between the University of Michigan and the MIMIC4 datasets. So this highlights the variability between patient populations and the need for models that can perform well in different clinical settings. So these histograms visualize the differences between the two datasets. The upper panels are from the University of Michigan dataset. You can see the distribution of daily tacrolimus doses and the trough concentrations. The mean trough was about 9.6 nanogram per ml. The target trough concentration was between 8 to 12 nanogram per ml in the first months at the University of Michigan Transplant Center, the first month after transplant. The lower panel is a MIMIC4 data set. You might have found that both the average dose and the average trough concentrations were lower compared to the University of Michigan data set. The differences might be due to different protocols used by the two transplant centers. MIMIC4 may have a different tacrolimus target range. I'm not sure about it, but it could be. So in clinical practice, we take multiple trough measurements during the first week after transplant to adjust the dose. The scat plot shows the trough concentrations over the first week. You can see a wide spread of concentrations at every time point. The blue box shows concentrations within the target range, which is 8 to 12 nanogram per ml. Most of the concentrations were outside of the target range. The bar chart on the right side shows how many trough measurements we had per patient within the first week in our University of Michigan dataset. Over 60% of patients had only 2 measurements, and very few patients had more than 4 measurements. So the data were very sparse. So our first approach was to develop a population PK model, or POP-PK model, to predict tacrolimus trough concentrations. So this is a conventional method, but still the most commonly used approach for PK analysis. So POP-PK can be combined with empirical Bayesian estimation, then can be used to predict the PK parameters of individual patients. So this table shows the results of our POP-PK analysis on the University of Michigan 4 dataset. One compartment model was used as a final structure model. In this case, we prefixed the Ka value based on previous report because we only had trough concentrations which did not provide sufficient information to estimate the absorption, the Ka. So we identified several key covariates that affect the tacrolimus clearance, such as body surface area, age, race, and hematocrit. And for example, being African American was associated with a 26% increase in drug clearance. So here are some diagnostic plots, which essentially confirm that our model is robust and it describes the data well. So then we analyzed a subset of 376 patients who had genetic information, including the genotypes of CYP3A4, CYP3A5, and ABCB1 genes. So these genes are involved in the metabolism and disposition of tacrolimus. So here are the results of the POP-PK analysis. So in this model, we found that CYP3A5 genotype was a significant covariate of tacrolimus clearance, which is consistent with previous reports. So other significant covariates on clearance include like age, body surface area, hematocrit, similar to what we found on the full data set. So again, the diagnostic plots shows that this model fits the data very well. So how well did our POP-PK models predict the trough concentrations? So here we used empirical Bayesian estimation to estimate the PK parameters for individual patients, and then used the individual PK parameters to estimate tacrolimus trough concentrations. So this plots shows the model's predicted concentration versus the actual observed trough concentrations. A perfect model would be that all data points lie on the identity line. As you can see, the model used the genotype data, which is on the right, performed slightly better with lower mean squared errors, mean absolute errors, and a higher R-squared value compared to the model without the genotypes, which is on the left. So this confirms that including genetic information can improve our model performance. Next, we want to see if modern machine learning models could outperform the traditional POP-PK model. So here we tested two machine learning models. The first model is extreme gradient boosting, or XGBoost model, which is a tree-based model. We chose this model because it showed good performance on predicting steady-state tacrolimus trough concentrations in previous studies. The second model we tested is long short-term memory, or LSTM model. LSTM is a type of neural network which is well suited for sequential data like our time series tacrolimus trough concentration data. So in this study, the last tacrolimus trough concentration and the various clinical features such as patient demographics, lab results, and co-administered medications were used as features to develop machine learning models. So in this study, we predicted a trough to daily dose ratios instead of directly predicting trough concentrations. The reason is that XGBoost and LSTM are nonlinear models. So if we use the models to directly predict the trough concentrations, then the proportional relationship between tacrolimus dose and exposure will be violated. Once the trough to dose ratios are predicted, we can easily calculate the predicted trough concentrations based on the dose and the predicted ratios. To ensure our models were robust and avoid overfitting, we used a technique called a nested cross-validation. So basically, we first divide our data into training and test data sets. The training data was further split into 5 folds. And our model was trained 5 times using a different fold as validation for each training iteration. The final model was then evaluated using the tested data, which had not been seen by the model during training. So this approach provides a more realistic estimate of the model's performance on unseen data. So here are the results from our XGBoost model. The upper panels are the trough to dose ratio predictions. The low panels are the predicted trough concentrations versus observed trough concentrations. So again, the model with genotyping information, which is on the right, performed better than the model without genotypes based on MSE, MAE, and R-squared values. So this demonstrates the value of including genetic data in machine learning models for tacrolimus trough prediction. So we performed a feature importance analysis of the XGBoost model. So in the model without genetic information, which is on the top panel, the most important predictors were the patient's previous trough to dose ratio and their previous trough and dose, followed by clinical factors like race, age, and weight. Now, when we look at the model with genotyping information, the CYP3A5 genotype was the second most important feature, right after the previous trough to dose ratio, suggesting that patient genetic makeup is a critical piece of information for the model performance. So this slide shows how machine learning models can improve clinical tacrolimus dosing. So as you can see, across all patients, only about 37% of trough concentrations were within the target therapeutic range in the first week post-transplant, which is between 8 to 12 nanogram per ml. 40% of the trough concentrations were below the target, and 23% of the troughs were above the target. So based on the trough concentration prediction by the XGBoost model, we calculated the doses required to reach the target range. Now we have 2 dosing groups, right? So one group consists of doses within the dose range recommended by the XGBoost model. And the other group contains doses outside of the recommended dose range. So we find that when patients received doses within the recommended dose range, more than 50% of their troughs were within the target range, between 8 to 12 nanogram per ml, which is about 35% higher than that of the entire patient population. In contrast, for patients who received doses outside of the recommended dose range, only about 26% of troughs fall within the target trough range. So we have a big difference here. As I mentioned earlier, we developed two machine learning models, XGBoost and LSTM. So I have only discussed the results from the XGBoost model. This table provides a head-to-head comparison of the two models. We tested their performance on the full data set and the genotype subdata set. Overall, both models performed very well, but I would say that XGBoost might be slightly better than LSTM in most scenarios based on MSE, MAE, and R-squared values. In addition, because XGBoost can easily handle missing data, so we selected XGBoost as our final production model. Both models have better performance on the genotyping subset, just like the population PK model. Okay, now we want to see if machine learning models can outperform the PopPK model. A crucial test for any model is external validation. So can the model work on the data it has never seen from a different hospital system? So we tested our XGBoost model and our PopPK model on the MIMIC4 data set. I think the results are clear. The XGBoost model, which is on the left, was more accurate with lower MSE and MAE values and higher R-squared values compared to the PopPK model on the right. So this demonstrates that the machine learning approach is not only powerful, but also more generalizable. Now, to make our machine learning model accessible to clinicians, we developed a web-based application to implement our trained XGBoost model. You can use this link to access the app. So let me quickly demonstrate this web app. One second, let's see. Okay, it's here. So yeah, so here is the interface of the of this app. Here you can enter the target tacrolimus trough concentration you want to have in your patient. For example, I can enter, say, 8 as the target. Then I will provide, patient's information such as age.
Dr. Zhu, we're not able to see the app window. So if it won't come up on the program, maybe you can just describe what you're seeing.
Okay, maybe I can stop share and then share again. Sorry about that. Give me 1 second. Can you see it now?
Yes.
Okay, great. Yeah, sorry about that. So yeah, as I mentioned, so this is the interface of this app. So you can enter the target trough concentration you want. Of course, you can provide other information such as patient age, race. So those are optional, information you can provide. For example, you can provide the genotype information if you have. Then you just click predict. Then the XGBoost model will estimate what is the daily dose required for the patient to reach the targeted trough concentration. In this case, the patient will need 9.6 milligram and to have nanogram per ml trough concentration. So I think it is very easy to use. I will encourage you to give a try if you are interested. I would appreciate it if you can share your thoughts about the app after using it. Okay, let's go back to the presentation. Stop sharing. Let me share again. Okay.
Yep, looks good. We're back in the slides.
Okay, good. Okay. So in conclusion, for our first project, we have shown that machine learning models, particularly the XGBoost model, are powerful tools for individualizing tacrolimus dosing. They can improve patients' chance to reach the target therapeutic range early after transplant, potentially reducing the risk of adverse events caused by over or underexposure of tacrolimus. Okay, so now let's shift gears to our second project, which is about another major challenge in kidney transplantation, predicting rejection. So rejection is a major risk factor for graft loss. Currently, the gold standard for rejection diagnosis is a renal biopsy. So, however, this method is invasive and very expensive and is not routinely performed in the clinic. So we need a non-invasive method that can predict rejection risk in kidney transplant patients. Early detection can allow us to, do early intervention and improve the long-term outcome of kidney transplant patients. So the goal of this study is to combine LC-MS-based metabolomics and machine learning to predict rejection in kidney transplant recipients. So here is the overview of the study design. We started with 950 plasma samples from 119 first-time kidney transplant patients at the University of Michigan. We focused on samples collected within 90 days before a biopsy to build the metabolomics-based machine learning prediction model. We ended up having 315 plasma samples from 93 patients. We used untagged LC-MS metabolomics method to profile the metabolomes of the plasma samples and obtained over 9,000 metabolite features. So after data cleaning, a total of 870 metabolites were included in the final data analysis. We also collected the baseline clinical characteristics from the patients through the EHR. We then used the metabolites and the clinical features to develop machine learning models to predict rejection. So this is a brief overview of the 93 patients included in the final analysis. Now, this cohort includes a mix of ages, genders, and races, with 24 patients having experienced the rejection and 69 patients without rejection. We first looked at whether baseline clinical characteristics were associated with rejection. So these clinical features include like age, sex, race, kidney donor profile index, donor types, living or deceased donors, induction therapy, donor-specific antibodies, positive T-cell cross-match, positive BB-cell cross-match, A2B match CMV status, and the use of steroid avoidance protocol. So we find a significantly higher rejection rate among African American patients compared to white patients, which is consistent with previous reports. All other factors, however, did not show a significant association with rejection in our cohort. This slide shows the metabolomic study setup. We used a data-dependent acquisition methods for data collection. As you know, there's different data acquisition methods, data independent and data dependent. In this study, we used data-dependent acquisition method. The raw data were processed using the MS Dial software for picking and pick alignment. So this figure is the overlay of the chromatograms of quality control samples from 5 randomly selected batches. You can see excellent overlaps of picks, suggesting that the results were highly reproducible. Our metabolomics analysis lasted for more than 3 months with 35 batches. So this slide shows the variability of internal standards across all batches. The relative standard deviation was mostly below 15%, again suggesting that our data are of high quality and highly reproducible. So in this study, we prepared 4 different data sets for machine learning model development. The first data set only contains baseline clinical characteristics that I showed you earlier. The second data set has all 870 metabolite features. We performed principal component analysis. The third data set includes 63 principal components that explain 80% of the variance in the metabolomic data set. The final data set is the combination of baseline clinical features and the 63 principal components. So in this study, we tested a very broad range of machine learning models, 16 in total, to see which would be the best for this classification problem. The models included everything from linear models to neural networks and tree-based models like random forest and XGBoost. The model hyperparameters were optimized using the grid search method implemented in the scikit-learn package. So this slide shows the model prediction performance among the 4 data sets across different models based on receiver operating characteristic or ROC or ROC curves. The AUC tells us how well a model can distinguish between rejection and non-rejection cases. An AUC of 1 is perfect prediction, and the 0.5 is just a random guess. The top left plot shows that using baseline clinical characteristic alone had AUCs around 0.5, meaning that the models cannot effectively differentiate rejection and non-rejection cases. However, when we use other data sets, especially the complete 870 metabolite data set, the performance improved dramatically. Some models had AUC above 0.8. So this tells us that metabolomic profile contains a very strong signals for predicting rejection. So this table summarizes the performance of our 4 best performing models that were based on the metabolomics data. So these 4 models are XGBoost, Gaussian Naive Bayes, multiple layer perceptron, and random forest. As you can see, models like XGBoost achieved a very high accuracy of 84%, which is very promising for a non-invasive test method. To be sure, our method was not a statistical fluke. We performed a permutation test. So basically, in this test, we shuffled the label, which is a rejection or non-rejection, and then retrained our models on the shuffled data. We confirmed that our original scores were significantly better than the scores from the shuffled data. So the results demonstrated that our model performance is not due to random chance. So these figures show the confusion metrics for our top 4 models. As you can see, where the models make their correct or incorrect predictions. For example, the XGBoost model correctly identified 54 out of 54 non-rejection cases and 5 rejection cases, while misclassifying 11 rejection cases as non-rejection. While not perfect, it provides a solid foundation for the development of a non-invasive tool for detecting rejection. In conclusion, for our second project, we have demonstrated that combining on-target metabolomics with machine learning is a very promising approach for predicting rejection in kidney transplants. The metabolite signatures in a patient's plasma appears to contain some powerful predictive information that could one day lead to a non-invasive test for monitoring rejection. Yeah, the test could potentially reduce the need for invasive biopsies and allow for early detection and early intervention. Okay, so of course, this work will not be possible without our fantastic team. I want to thank my collaborators, Dr. Jamie Park, Dr. Lu, and Dr. Evan Prakash for their support and valuable advice. And I also want to thank my lab members for their hard work. Okay, thank you for your time and attention. And I'm now happy to answer any questions you may have. Thank you.
Thank you, Dr. Zhu, for an excellent presentation. We do have a few questions here. We'll start with the first project. Would you mind walking us through again why you used the trough to dose ratio in predicting the tacrolimus exposure in the machine learning model? Just at a brief high level.
Yeah, of course. Yeah, this is an excellent question. So actually, at the beginning, we did directly predict trough concentration using this machine learning model. But one thing we noticed that when we use the models to directly predict trough concentration, when we make for example, when we make a small change of dose, the trough concentration can change dramatically, or vice versa, right? Then we realize that our models are nonlinear model, right? So if we use if we use the model to directly predict the trough concentration, then the dose and trough concentration is no longer the linear relationship, right? But if we can use our model to predict the trough to dose ratio, then we can use the ratio to calculate the trough.
Mhm.
So that will, maintain the linear relationship between dose and trough. So this is
So
the
when
main reason we end up using trough to dose ratio as
okay.
a label instead of directly predicting trough concentration.
So when you were taking the measurements to train the model, did you uh, find the trough at take multiple measurements or a single point to measure the trough in the data?
Um, Yeah, we did that. We use the simulation methods. We tried different trough concentrations. We tested what doses were needed for the trough concentrations. So this
Mhm.
is how we find that there's lack of linear relationship or proportional relationship if we directly you know predict the trough concentration.
Okay, but in the data analysis that fed into the model in the first place, were trough concentrations in the data found at single time points, or were there multiple measurements? I think that's what the question's about.
Oh yeah, yes. So we used the previous trough concentration.
Right, right.
So
That's what the
so
question's about. Yeah.
yeah,
Is it
yeah.
one time point or
Just
multiple?
one time point.
Okay,
Yeah, it's
thank
one
you.
time point. Yeah, but for POP-PK model, of course, we include all the trough concentrations. But for machine learning model, we only included the last trough concentration, the previous last trough concentration.
Okay. Next question is about the app. In the window, some of the input variables were optional, like the genotype information. However, they appeared to be included in the model development process. Can you elaborate more on how the model predicts the recommended dose when some of those variables are not available?
Yeah, yeah. Right. So actually, we use the two different type of data sets for model development. So we have this the entire data set from the University of Michigan. We didn't use genetic information in that data set because the majority of those patients did not have genotypes available. Right.
Mm,
Then we have a sub data set, only have like 376 patients. So those patients had a genotype information. So we have two different data sets. So we basically have two different models. You have
gotcha.
one model without genotype, one model with genotype.
Okay,
The
so
model with, yeah,
it can
yeah,
calculate in either case then.
right. The model with genotype has better performance, but we still can get a decent performance for the model without the genotype. Yeah.
Okay, and then you may have already addressed this one in the talk, but did you do a comparison of using XGBoost to predicting trough concentrations when compared to a normal POP-PK model?
Um, yeah. So let me show the. Yeah, yeah, this is a comparison between the machine learning model XGBoost and POP-PK model. So as you
Mhm.
can see,
Yeah, higher R squared.
yeah, the performance of XGBoost model is better than POP-PK model. Yeah.
Thank you. The next question, I think, is a practical question. How expensive is the LCMS that's needed to obtain the metabolite information? Just in rough terms, is it something that a clinician is likely to employ in their lab or
Yeah,
in their screening service?
yeah, I think so. I think so. So in my lab, we do genomics, proteomics, and metabolomics. If I have to compare the cost, among the three omics methods, I would say metabolomics is the most cost effective, right?
Mhm.
Proteomics can be very, very expensive because you need to digest your proteins. It takes a long time. And also the reagents like enzymes can be very expensive. But metabolomics I think it's actually very straightforward. So like in our case, we use the direct protein precipitation methods. We add some organic solvent to plasma, we vortex it, we centrifuge it, then we collect a supernatant, for injection. So it takes like 30 minutes for sample preparation, and for the gradient, we use the 30 minutes gradient, so it's much faster compared to proteomics analysis. So because of that, the cost is relatively low. Because we have our own instrument, so it's hard to determine how much actually we have to spend on the assay.
Okay.
But I remember if you like here at the University of Michigan, we have metabolomics core. I think that the cost is reasonable. I can remember exactly on the top of my head, but it's not that expensive. Definitely is feasible for clinical implementation.
Thank you. What about, have you explored combining other metrics in the model, for example, a frailty index or psychosocial measures?
That's an excellent question. Yeah. We haven't yet, but definitely that can be potential important features for model performance. And also you might notice that for the second project, we only included the baseline patient characteristics. So right now we are collecting, labs and other clinical data after transplant. Right? So we want to build this dynamic model, including all these potential features. Hopefully that will improve model performance. Yeah.
Okay.
So this is one of the reasons we want to do this machine learning approach, because those models are excellent for those high dimensional data.
Great, thank you. Next question is, how early does the metabolomics approach predict rejection? What was the time point for the sample collection?
Exactly. So that's very, very important question. As I mentioned during the presentation, we collected or we only analyzed samples collected 90 days before biopsy, because we need a biopsy to confirm whether the patient had a rejection, right? Then we need to decide when plasma samples should be included in the metabolomics analysis, in the machine learning model development. So 90 days we choose is sort of arbitrary, right? So
Gotcha.
so we thought if we have a cutoff date too close to biopsy, then the prediction value of the model will be less, right? Because we want to predict the rejection like weeks or even months before rejection actually happened, right? But we also don't want to have samples, like many months before rejection, because maybe at that time nothing was happening in the patient, right? So we can introduce a lot of background noise in our data set. So so again, the 90 days is a little bit arbitrary. So what we want to address is in the future, we want to have all data, but instead of using like one specific data point, time point, we want to see the change of those metabolomics features over time, right? That might provide more information that can also partially address, when we should collect samples. Yeah, but that's an excellent question. Thank you.
Thank you. Next question. This again relates to the clinical application. Has this been used yet in any clinical practice? And if not, what do you foresee as the bottlenecks to implement this?
Yeah. No, this is a very early study. So as you can see, it's a retrospective study, right? So we collect samples, from the hospital, and so I think the first step is to increase sample size. So right now, like in this study, we only had 93 patients. So it's a very, very tiny sample size for clinical research, right? So actually right now, we have collected more than like 300 subjects, over 2,000 samples. We are continuing the sample collection. So first we need to increase sample size. And the second most important thing I would say would be to do a prospective study instead of this retrospective study. So
Okay.
maybe we can have a study of patients into two groups. So one group of patients will have the standard of care, right? And then another group will use the metabolomics machine learning based method to predict the rejection. So then we can look at the two groups to see whether they have different clinical outcomes, like graft survival and overall patient survival. Before we have all this data, I don't think any hospital will adopt our machine learning model. Yeah.
Thank you. Did the metabolomic method predict rejection before there were symptoms of rejection in any of these patients? Or because it was retrospective, do we know that information or not?
Most of the patients didn't have any symptoms. So we look at the labs, like a creatinine level, and that reflects the renal function of the patients. No, the majority of patients did not have any symptoms related to rejection.
Interesting. That's great. Okay, so last question. This is a technical one. The LSTM model incorporates time sequencing factors, whereas XGBoost did not. Since this data set represents the complete drug time profiles, it's accounting for time sequencing might seem more appropriate. However, XGBoost appeared to have performed better than LSTM. Do you have any insights as to why that happened?
Yeah, this is the excellent question. So actually, at the beginning, when we decided to use the two models, we also expect STM model will perform better because it's designed for this time series data. But as you can see, actually, XGBoost model is better, right? So
and do you have a feeling for why, or do you have an explanation yet?
yeah, we I think the main reason is a data set. Okay, even though we have this time series data, but as I showed you earlier, maybe we can go through to here. Yeah, so as you can see, the majority of patients only had two trough concentrations, over 60% of patients, right? And very few patients had a 4 or 5 trough concentrations. So
even though there was time series, there weren't that many time points.
Yeah, exactly.
Yeah. Okay.
Yeah, exactly. So I guess this is the main reason.
Great. Well, thank you. I think that wraps up our questions. I'd like to thank Dr. Zhu again for his excellent presentation, and to remind the audience to please check the ROSA website or our email postings for upcoming webinars. And at this point, I'd like to say thank you and have a nice day, everyone. Bye-bye.
Thank you, Mike. Thank you, Heather.